Is it freezing? So I have the shoulder girdle first. Everybody, can you see that? I can't see chat, so someone just turn off your microphone.
The only thing we see is you.
Okay. Well, that is not what's supposed to happen. Okay, how about now? Popping up?
Yes, ma'am.
All right, yay.
You're good.
That is perfect. So in chapter 5, at the beginning, we have the bony anatomy. So I'm going to talk about some of the key points to the shoulder girdle. It consists of the clavicle, scapula, and humerus. So the proximal humerus is what we're going to be looking at on our shoulder x-rays, pretty much. The head of the humerus that is going into the glenoid cavity or the fossa where it connects to the scapula and clavicle. And we have a bump on it, and it's more towards the outer edge of our shoulder, the greater tubercle. We have a bump off the front. It's more anterior, the lesser tubercle.
Hold on. Let me. Do you feel sick?
It's not muted. Okay, I think we're good now. In between the greater tubercle and lesser tubercle, you have this little groove, the intertubercle groove. More commonly, most doctors will say the bicipital groove. And we have an anatomical neck, kind of separating it up here in half. And we also have a surgical neck where they cut the bone if they're going to do a shoulder replacement and replace the whole head of the shoulder. We don't really talk about deltoid tuberosity too much. And then the long part of the humerus, the shaft or the body. So on our radiograph, you're going to need to locate that anatomy. So the arm here is positioned in a true AP with the epicondyles being parallel to the IR. You're going to see this black space, that's the shoulder joint. That's where, if we're doing an arthrogram on the shoulder, when we start talking about that, we're going to inject contrast in there and see if there's any ligament tears or anything. Before MRI, that's how they looked for that. Now we have MRI. We can see the head of the humerus. Letter E is that anatomical neck. Letter B is the greater tubercle. Letter C is the lesser tubercle. See that white line of it? That whole shadow is the lesser tubercle that we see. F, surgical neck, and G, body or shaft. So A is just talking about the joint or the glenoid fossa or head of humerus, sorry. The space here is the shoulder joint. We see a little shadow of a bone here. This is part of the scapula. This is the coronoid process we're going to talk about in a minute. And we see another piece of the scapula poking out here. This is the acromion. And then we have the clavicle, the shadow of the clavicle coming across. And here it is in the bony anatomy. So looking at the clavicle, we need to see both joints of the clavicle, where it connects to the sternum, the SC joint, and where the clavicle attaches to that bony projection off of the scapula, the acromion of the scapula. So the AC joint, acromion clavicular joint. Here's the coracoid process. So it's hard to feel. If you poke on yourself, hopefully you can see me, right underneath the clavicle, there's a little indentation, a soft spot. If you push really hard, I mean, it's not like, ouch, I'm gonna die pain, but it's a little tender. It's a nerve that attaches there to the coracoid, muscles and tendons attached there. It's probably about a finger or 1 or 2 fingers below the clavicle. Can everybody feel that? Kind of. You might not feel like a big poke of bone. It's more just a tender spot. there's muscles and stuff kind of in the way there. If you poke beside it, it doesn't really hurt, but when you poke right on it, there's a little pain. I can't see chat or anything. Somebody say if you feel it or not feel it. Anybody? Let's see. Let me
Oh,
go.
I'm sorry. Yes, I can feel it. I was just saying it is definitely tender.
Yeah. So you're not going to want to poke on a person if they're hurting and make it even more tender. But I know you guys are just learning and practicing and you want to be exact. For our centering, it uses the coracoid as a reference point. So if you kind of approximate that 2 fingers below the clavicle there, that's easier to feel than poking on someone's coracoid and hurting them. I have these hummingbirds that come and I just saw 2 of them fighting. One's chasing the other one away. Crazy. So I'm just in the lab on each other. You can feel your coracoid. I'm just saying you're probably not going to poke on someone's coracoid if their shoulder's broken or hurt. So we're going to need to eyeball it approximately, figure it out where it's at for people. I don't think I've ever palpated the coracoid for a patient. You'll be able to eyeball it. I'm going to show you the trick for the light of the collimation too. But you need to know specifics for test purposes, especially for the registry, the centering when they reference it to the coracoid. Here's the bone that we're talking about, the greater tubercle and the lesser tubercle poking out in the front. When we look at our view, which we call this the lateral view, the scapular Y view, lateral scapula, we do this view on the shoulder and we do this view for the scapula. So it throws these every time my class, you guys are like, it's so confusing. They're positioned the same, except for you move the arm a little bit and you move the central ray a little bit. Don't get confused. The wording is weird. For the shoulder, it's called a lateral scapular Y view. For the scapula, it's called a lateral scapula view. I don't know why they named it so many different things to confuse us, but that's just what they did. The scapular Y view basically puts the scapula on that side. We're looking down through the back of the patient through the shoulder. So if anybody looked at that video last night or looked over it in your book, this is the view we were talking about. So it may not have made sense yet. We're going to see the head of the humerus. In this picture, they have moved the humerus across the body. See how you can see the arm coming across the ribs here. For a shoulder, we are going to keep the humerus down. So you're going to see the scapula, the body of it, overlapping the humerus. So just depends on if we're doing it for a scapular picture or for a shoulder picture. And we're going to talk about those separately, 2 different boxes on your matrix you're going to fill out.
All right, I do have a question, ma'am. I'm sorry. This picture's kind of messing me up and I got to figure this out.
Okay.
All right, so they're up against the IR with their back against the IR.
No, well, you could do it that way, but in the picture in the book, it should be their shoulder touching the IR.
Okay, the shoulder touching the IR, that would be their left shoulder touching the IR. And their arm across their body.
Yes.
So that's where they get the lateral.
Yeah, so it's lateral because we've turned the scapula on its side laterally. It's not flat against the board AP anymore. It's a lateral scapula.
Okay, so they're not actually turned all the way to a lateral, so it's going through their body.
No.
It's just the scapula.
Just the scapula.
Okay, now I get it. Now I see where what you're cooking.
Good. So some anatomy we need to orient ourselves with when we're looking at this picture is the acromion that pokes out, and I'm going to bring a scapula of the scapula into the lab. The coracoid process pokes out this way. So I call this a V shape, the V or the triangle of the Y, and then the stick part of the Y, the straight up and down, is the body or the spine here. And we can also say if the humerus is down overlapping it, the humerus makes up the straight up and down part of the Y. So it's dotted here on the picture. So acromion is over here. Coracoid sits towards the middle, and here more towards the ribs.
Okay, now I'm messed up. E is the humerus. That's the bone that goes down, but they have their arm across their body. If you go to B, the black dot on B, and where it hits the end of the V,
Uh-huh.
that bone that goes across at a 45-degree
Yeah.
angle, that's there.
The humerus.
That's the humerus. And when you said E is what?
The body of the scapula. So this bone
Oh,
scapula,
okay.
the body of the scapula.
Okay. I was thinking that was the humerus. It was E, and I was like, how is that possible? Okay, I understand. All right, cool. I'll shut up.
You're fine as long as you get it. You don't want to get it wrong. So we have acromion, coracoid, and the body of the scapula here. When we do this picture for shoulder, in a minute I'll show you it, the arm is not going to be across. It's going to be overlapping the body of the scapula. And we'll talk about why in just a few minutes. So the joints that we're going to have to know, sternoclavicular joint, acromioclavicular joint, and the scapulohumeral joint, or glenohumeral shoulder joint, also known as, man, my mind just went blank what I wanted to say here, glenoid fossa or glenoid cavity. Lots of things for this little area here. But the joint is the scapulohumeral joint. Yes, Sandrika, what you got?
So based off this picture, that's the clavicle going down, and that's the humerus right there along the side.
So clavicle is this bone across.
Yes. And then that's the humerus,
Humerus right here. Yep.
and that's the scapula right there in the back.
Yep. Going behind the ribs.
And then that's the little small bony part that we seen hanging down. That would be going down along the back of the ribs.
See back here on the medial side of it, this part of the scapula, this border here. This is called the vertebral border of the scapula. We're going to look at it in a minute on the scapula when you just dissect it. And this side over here of the scapula is kind of a triangle-shaped bone. Is the axillary border of the scapula. When you turn it lateral, them two are overlapping on top of itself.
Okay, so
Yeah.
where is, looking at this picture, where is that pointy end that we just seen on the previous slide before this?
The pointy end like
The
this.
body. The body.
So it's, see how it's a little bit of an angle. So over here is the axillary side, and this is the vertebral side, or this is actually the axillary side, the glenoid cavity side, and back here is the part by the ribs, but it's just looking at it down the bone. So this piece is that
So
triangle.
in the front way, it would be a triangle, but turned to the side. We're looking at it from the side. Okay.
Yes. Yep. So that's an AP view, and that is a lateral view of it, turned on its side.
I get it.
And then here's that bone towards the front that we poked on, the coracoid process. And here,
So based off the lateral view, we were looking at it from the left side,
yes.
because I'm looking at the bone right here, the little indentation that was on the last one,
Mhm.
and it's sitting on that bone right there, that little indentation, the glenoid cavity.
Mhm.
It was on the left side when we looked at the picture, the AP picture. So it's the left lateral position right here.
Yeah, that's a left.
Okay.
And this one's also a left. Yep. So I have the technique chart posted for you guys, around 70 to 75, usually about 75 kVp. We are going to use a grid because the shoulder's a thicker part, greater than 10 centimeters. We're going to use a higher MA station with a short exposure time, but mass is still going to be within that range of about 12 or 15 mass. Small focal spot because that's better recorded detail. Yes.
Okay,
Sandra?
you say we're going to use a grid. So it said the KVP is 70 to 75 and digital 75 to 85, but I thought a grid is only used when it's 90, 100 or better.
For chest.
For
Good.
chest, okay.
Yep. Or remember if it's 10 centimeters or thicker, the part, because of all the scat.
Okay.
AEC, does anybody remember what AEC is? Automatic exposure control. What does that mean?
It's a machine that you can go to and it'll tell you what the exposure is supposed to be for that body part. And if you click the button, it'll automatically like set your timer, your exposure and all that stuff.
Okay. I think you're talking about APR, like you push a button on the computer and it gives you your technique.
Yes.
That's APR, anatomically programmed radiography. That's a computer program for the system. So our digital room has that, but our other room has all the dials we got to do. It doesn't have APR. So in APR, it could have it set for AEC. So either think about it again, or anybody else remember AEC, automatic exposure control.
It's going to automatically set the time, the KVP, the mass, to a predetermined set of parameters.
That's still close, but no. You're almost right at the beginning, but then you threw in KVP and stuff. So that is
maximum amount of mass that's allowed, the maximum exposure.
Who's that?
It's Emma.
Okay, Emma. So the exposure has something to do with exposure, the maximum amount. There's a timer involved. Okay, there's a clue on here that says center chamber. Does anybody remember learning about ionization chambers?
The three squares.
Yeah. So we have 3 cells that are built in our wall bucky and our table bucky. And those cells detect radiation. When there's a predetermined amount of radiation that reaches them, it terminates our exposure time. That's where automatic exposure control, the initials, come in. So if you have a part over a cell and you've selected that cell to be on or activated, it's going to have a predetermined amount of radiation that it's going to allow for that part that you've picked. So every part in the APR, the anatomically programmed on the computer, when you pick shoulder, it's going to know that cell has a certain amount it expects you to have for a shoulder. If I was doing an abdomen, it would have a certain amount that it was set for an abdomen. If I was pick spine, it would have a certain amount that cell would be expecting to get for a spine. When a certain amount of exposure has reached it, it's determined that we have used enough of our photons that have come through to give us a good X-ray, and it will terminate the exposure for us. So we have our KVP and our MA set automatically on the control panel, but we are not setting the time part. That exposure chamber is telling us our time. As we're exposing, it's going through. When the photons have reached it, it'll terminate our time, and then it's going to give us a mass on our computer screen after you're done, because it's going to tell us, okay, we've got enough, and it's going to terminate the exposure. So our time is not picked until after you hit the button and expose. When the chamber feels like it's got enough, it's going to shut off. Does that make sense?
Yeah, it's like the little turkey button.
Yeah, that pops up when it's ready. Yeah. So AEC only works if you have the right chamber selected and the parts over it the correct way. So Miss Dean hates AEC. I don't know how much she told you she hates it. Don't use it. Because if you do not center right, you're not going to get a good exposure. So if I was doing my shoulder, but I didn't have my bone over it and I had my fat, my soft tissue off-centered over the cell, the exposure is going to get there faster because it's not going through bone, it's going through soft tissue. So it's going to terminate early, the exposure is going to reach the cells quicker, and my picture is going to be too light. So just because you use AEC does not mean you have selected a good technique. It's not giving you a technique. It's not giving you a proper technique. I get that a lot of times on questions whenever I have a fill in the blank. What does AEC do? I get people telling me that it is setting my technique. It doesn't set your technique. AEC controls the time, which will give us our mass in the end, and it only works properly if we are using it right. Do I use it as a tech when I'm at the clinical site? Yes. Do the techs use it every day? Yes. So just because it's a lot easier than having to figure out what your mass is going to be for every single body part. It only works if you're using it in the bucky though. It doesn't work for tabletop because the chambers are built into the buckies. And then we're going to use 40-inch SID on almost all of our shoulder, except for when we get to the AC joints, because we need both of them on there, and to get both sides of our shoulders is going to be impossible at 40 inches. We need to reduce magnification too, so we're going to use 72 on AC joints. Here's a little chart with our different classifications and movements. That's also in the chapter. Scapulohumeral joint is a sporoidal or ball and socket type of movement. That's what you think of, number one, when you think of shoulder joint. Sternoclavicular joint, where the sternum meets the clavicle, is plane or gliding, and acromion clavicular is plane or gliding. So easy to remember those two. They just barely move with each other. Those joints don't have a lot of movement. Then we have a picture of those joints again, a radiograph, the scapulohumeral joint, acromion clavicular, and sternoclavicular. So when we're moving our arm for our pictures that we're going to do for the humerus and the shoulder, we're going to do external rotation and internal rotation views. So external rotation basically means that we are putting the epicondyles, that elbow, in true AP, so they're parallel to the IR. That's going to show up on our radiograph where we can see the greater tubercle in profile or on the lateral side, on its side. The lesser tubercle is going to come in the true AP in the front. So A, greater tubercle, B, lesser tubercle. When we do our lateral view, we're going to turn our arm in. So the back of the hand is resting near the hip or the leg area. And that's going to rotate in those epicondyles till they're perpendicular to the IR. So like a lateral elbow. The greater tubercle is going to move in. The lesser tubercle is going to move in medially. So the lesser tubercle is now seen in here medially, and the greater is kind of in the middle because of that rotation. So that's how you can tell which position your X-ray, your arm was in the X-ray. This is used on humerus and shoulder when we get to those positions.
Can you go back one frame? Okay. Just so that way you know, I know that so if the A is all the way out, that's AP and turned back towards the butt.
Yeah.
And then the other one is your hand is flipped over.
Yep.
Okay.
If you don't have, if you have a patient who's trauma and they can't move their arm, we're just going to say neutral or as is. So in neutral, you're going to have both in the middle. Kind of a weird looking picture. We don't do neutral, not generally as a picture, unless for some reason your patient absolutely can't move. So both of them are going to be kind of sitting in the middle on neutral. So here's all three. What do you guys think A is? Type it in the chat. I'm trying to get it to let me see the chat. It's kind of a pain here. Maybe I got it in the show. I don't know why. Chat. All right, I guess I don't have to look. If you said letter A is external rotation, you are good. I don't know why my mouse was stuck.
Okay, so the A is external.
Yep.
Then B, since it's so far in, would be internal. You've got your thumb back towards your butt.
Yep.
And then C is neutral if they can't move at all.
Yep. Exactly.
Neutral or internal?
No, neutral is neutral. Internal is
neutral. Okay.
So here's a saying that we kind of made up somewhere. I think it was cohort 30, 31, something like that. Maybe it was even cohort 28. But jelly, greater is seen on external, lesser on internal. So if you want, and you like little acronyms, or if you can just remember by moving your hand which one's doing what, whatever works for you. So now the positioning. So the first one is the humerus. Try to find the page number for us. I flipped way too far. Page 187. So this is the AP view of the humerus. You can do it standing or laying down. I just think it's easier for us in the lab just to do everybody standing. We need from the shoulder joint all the way down to the elbow, and the central ray is mid-humerus. 14 by 17 IR size. And in the video, I think it shows her turning the collimator. If you want to do corner to corner, you can. We'll show it in the lab, depending on who your patient is. You may have somebody with not a very long arm and they fit good just straight up and down. If you need to go corner to corner, you can bring their arm a little bit away from them and kind of go crosswise on the IR. As long as you have both joints and your light is centered to the middle of the humerus. And then our other view we're going to do is a lateral. There's our x-ray. So it's externally rotated so the epicondyles are parallel to the IR. Important words there. Going to be tested on that. We're going to see the greater tubercle in profile out on the lateral side. Now here is our lateral. Two different ways to do it. Somebody had a question? Yeah.
The greater tubercle is that little point on the side right there?
Yep, that little bump.
Okay.
Yep. So we could do lateral to medial projection or medial to lateral projection. It's up to you. I think about 90% of you guys are going to just do them standing AP with their back to the board so that you can just keep it how you had it for your AP view. This is a lateral humerus because we are turning the arm and making the humerus lateral. The patient's still standing the same. So we're going to make the elbow look lateral so the epicondyles are perpendicular to the IR. The facing the board one though, if you have a difficult patient who can't do that, it's much easier and it's easier to get the humerus flat on the board. I've done it this way a lot of times. So either method, whatever you want to do, you just kind of have to return your collimator and all when you go from the AP to the lateral if you do the patient kind of like the lady is facing the board. I think I've never had any students do that in comps. Yeah.
On the picture on the right, she has her thumb not in the anatomical position.
No. Because we're turning it in until the epicondyles are perpendicular to the IR. So we're rotating the hand until that happens, however much it takes for the patient.
Okay, that's internal.
Internal, yep.
LI. Okay.
Yep.
Right.
Center to mid-humerus. So that's our two things. Yes, Sandrika, what you got?
Okay, so internal is when the hand is turned in towards the body, and external is when the hand is turned out in the anatomical position.
Yep, yes. And just because you have it in anatomical doesn't mean you might not have to go a little bit more or less, just until those epicondyles are parallel to the IR on external. So the palm up, externally rotated and the thumb away a little bit, but it's however much it takes to get the epicondyles straight. And that's if they were laying down, epicondyles are on their side perpendicular to the IR.
And
That's
that would have laying down with the hand in, that would have been internal.
Internal, yes, exactly. So we want to see everything from elbow joint to shoulder joint. Again, on the lateral, it's going to look like a lateral elbow, and the AP is going to look like an AP elbow down there. Lesser tubercle medial or in profile medially up on the shoulder side. And this one's really turned in. You can't really see it that good, but no bump over here like a greater is not seen. So the projections for shoulder. This is a chart for you guys. Lots of projections we're going to talk about. Some of these are at ortho clinics. The doctors want to do them, and so we will go over all of them in this class. For your comp, write this down somewhere. We are going to do the internal and external shoulder views, which I haven't shown you yet. I just showed the humerus. We're going to get to the shoulder now. And then we're going to do one of these special views. There's the Gracie method. This is an oblique that I'm going to tell you about. And we have a Y view that's over here in the trauma views, the scapular Y. So make a note. These are the 4 pictures that you could do for comp purposes. You're only going to get one of these specialty views, the Gracie or the scapular Y. But I'm going to show you all 4 of them in the lab tomorrow. External and internal rotation for the shoulder, the Gracie method, the oblique, and the scapular Y view. These are the ones we comp you on and want you to practice the most because you are going to see those as the routines at most of our clinical sites. It could be that one site does the internal external with the Gracie, another site maybe internal external with the scapular Y. That's their routine views they do every time a shoulder order gets done. So those are the main views we want you to master and know how to do. The extra views are orthopedic views, specialty views for different pathologies and different reasons. So we're going to talk about those on our special view day next week. So we will talk about them, but we will not comp them. If you go to a site that does do these views, they're going to show you the way they like to do them, and you'll learn it at the clinic site, the way they want to do it. You'll practice it and get really good at it. And there's more than just these. Some doctors make up their own, and you just learn that at that site. So orthopedic clinics where I'm talking about, like JOI or somewhere like that. So again, write down, make a note for our comp for the shoulder, and we're going to practice these in the lab tomorrow. We're going to do an internal and an external rotation, which is what we just looked at with the humerus, but centered on the shoulder. And we're going to do the Gracie and the scapular Y view for the shoulder. And there's a special note in our book that says, do not rotate the arm if a fracture or dislocation is suspected. So we are not moving them if we think they have a fracture. Just do a picture as is, and we will do adjustments and move the body. We won't move the arm. We won't rotate the arm, internal and external. So here is our first external rotation, which is considered the proximal humerus, just the upper part of the humerus, the head of the humerus, the shoulder, and external rotations. So this is a small 10 by 12 IR crosswise. So I forgot to tell you the page number for lateral humerus, 188. So humerus, two pictures, 187, 188. And then this picture right here is on page 191, the first view for shoulder. AP external rotation, centered 1 inch below the coracoid process. So we kind of go, right, there's the shoulder, there's coracoid, so another inch. I usually say about 2 fingers down below that is about 1 inch. You may have to measure your fingers. If you have really tiny hands, it may be 3 fingers. We have you seen the calipers with the little ruler on it in the lab? You might have used that for something. Trying to think. Maybe not, unless you guys used it to measure for your fingers for the chest. But we'll measure you if you need to measure.
Yeah, we did use it from going from the inferior notch or the vertebral prominence. So we were 7 or 8 inches to know how far we needed to go down.
Far, yep. So we'll measure your fingers if you need to for the inch or 2 inches, whatever, if you don't already know. We want to have at least most of the clavicle showing on our shoulder x-ray. So the book, it says, I think, landscape or portrait if you're wanting to see more humerus. So most of the places I've been do it crosswise. Up and down just depends on who you're working with. So well, I think our little matrix thing that we gave you to copy off of that video said to do it landscape.
All right.
Crosswise.
And you did say that you would tell us how to find the coracoid process. Now I can find my clavicle, but I guess I'm just too fat and can't find it.
It's hard to feel. It's not like a hard bone like you're going to feel like the humerus or your epicondyles. So when you push that little indentation right about 1 inch below clavicle and you push hard in there, do you feel a little pain, like a slight? That's it.
Oh.
Yep.
Okay.
That is the tendons wrapped around that bone that you're pushing on. So if you push side of that, it's not as painful.
Right. So then you find that and then you go down 2 inches.
1 inch.
Okay. 2 fingers. Okay.
Yeah, about 2 fingers. And if you have bigger fingers, it may be 1 finger. I don't know. So you have to measure. Shielding on our shoulder and humerus is just the waist apron. We can't put anything up here near the thyroid because it would cover up our clavicle. So this is our external rotation. We're going to see the same thing we see on the external rotation humerus. greater tubercle in profile. The center of our x-ray should be where our joint space is, the scapulohumeral joint. We should see a lot, almost all of the clavicle and the scapula, shadow of the scapula behind the ribs.
So if you're doing an external, so you've got your in an anatomical position, it's going to open up that joint so that everything is open so you can see in there, correct?
Well, you can, kinda.
But
Look
if you
on
go
the head,
internal, it's gonna close it, correct?
it's gonna overlap it even more, yep.
Okay, okay.
So see how it's not a true space? We can see the edge of the scapula touching the humerus.
Yes, ma'am. But if you were to
That's
flip it the
what
other
we
way,
see.
but if you were to flip your arm the other way, it would
It's
be even
closing
more
more.
overlapping. Okay.
Yep. So internal rotation, same centering. So once you do the external, you don't have to move anything. You're already married. Just turn the hand and you're ready to go. 1 inch inferior to coracoid process. And so that should be the next page, 192. Respiration, you do not want to have them moving or breathing on this. So we just tell them hold their breath, don't breathe, don't move. Doesn't matter if it's in or out, just as long as they're not moving. There it is. See how it is a lot more covered.
Yeah, I see that now. It's like, okay, I understand.
So that bump is the lesser. I don't really see the bump of the greater. Sometimes you see a line or a shadow of it, but it's kind of overlapping the scapula, so it's hard to see.
It looks bent into it.
It is.
Okay.
In some people, it shows up better than others. It's just, we always want to just know that what happens on this view is that the lesser tubercle comes in medial. And on external, the greater tubercle is over here on the lateral side. So that's how you can tell internal versus external. Here's the one that really shows the joint space. So that's why I didn't want you referencing it to the joint space. This is a special view to see the scapulohumeral joint, the Gray-Shee method. See how nice and open the joint is? The whole black line, that space.
Okay, so I can't see it on the picture, but you've got a posterior oblique, so that means your thumb is turned down on your right hand, correct? If you were taking a picture from the left picture,
Mm-hmm.
and if you're like that, that means your right thumb is downwards.
On this one, I mean, the greater is kind of out, so it's a little bit of an externally rotated, but we've obliqued the patient some, so it's not really as good as it is on the external, if that's what, so the hand should be palm up still.
Okay, yeah, that's what I meant. Like the thumb is going outwards, the palm is up.
Yep. It's on page 196 in our book. And you want a small little box collimation wise around that joint. We don't need the whole scapula and shoulder. We're just focusing on the joint. So for better resolution, better contrast, we collimate on this one. So I think it says an 8x10 is the IR size. We're going to be really small, about 4x4, 5x5 square. And I'll show you this in the lab tomorrow. We're centered at a point 2 inches below the medial border and 2 inches from the lateral border of the shoulder. So from the top of the shoulder and the side of the shoulder down 2 inches and in 2 inches. So we say 2x2 for the centering on this one. Body is 30 to 45 degrees towards the affected side. So if it's a right shoulder, you're going to be RPO. And if it's a left shoulder, you're going to be LPO.
So can you put your cursor on where that the CR is supposed to be?
About right here. So from, oh, why did it go away? From the top, about 2 inches down, and from the side, about 2 inches over. So 2 and 2 to be right in the shoulder joint, the glenoid cavity. And then this one doesn't really show the light that good. I guess this is the top of the light coming around. This is the line maybe for the side of the light. I can't really see it in this picture that good. But we'll go over this one in the lab tomorrow. So on comp day, everybody's going to do internal, external. Some people are going to do this view, the gray sheet. And for your comp, I'll have cards. It'll say for the joint, to see the joint space. And this is the view we use to see the joint space. The posterior oblique gray sheet method. I think almost every orthopedic office I've ever seen does this view. So if you go to an orthopedic outpatient center, you're going to be doing a lot of these. Here's what's happening. We're going 2 inches over and 2 inches down to get to that joint where the central ray is going to come straight through it. And you're going to oblique 30 to 45 degrees. The patient, it's going to depend on body habitus. Let's see if our book says a note. It just says it depends on how round their shoulder is. So you will probably start off with 45, take a picture, and if you need to adjust, you can adjust from there once you see it in clinic. But almost everybody works at a 45. So that's what we'll do in the lab. And it's easier to do 45 degrees than to figure out how much 30 degrees is. So another view of it, this is the other shoulder side. We want to see this space, this black line all the way through the humeral head and the scapula. So we can see the whole fossa there, sphenoid cavity. Here's the difficult one. Everybody has trouble when we talk about this one. It's not that hard once we do it in the lab. This is the lateral scapula view, that scapular Y lateral. So we are going to put the side that's hurt against the IR. So the right side is going to be RAO, the left side will be LAO. So we're going to be going down to the middle of the scapula, coming out about the neck of the humerus on the IR. And we could say we need about 2 to 2.5 inches of light above the shoulder. So that way we have room for our marker and we know that we're not going to miss the head of the humerus. The obliquity is going to depend on your patient, 45 to 60 degrees. Here's how we get this little line straight through. We want our central ray, this little pointer, to be coming through the body of the scapula and coming out straight with the AC joint, the acromion clavicular joint. So if we were to shoot an arrow through the patient's scapula and come out the AC joint, that's what our goal is. And when you have that line straight, that's how you know that they're in the right position oblique. So we're just going to feel that with our hand and do an imaginary line through the acromion clavicular joint coming out the front. So don't worry about the 45 to 60 degree oblique. It's just until you oblique them to get that line straight. That's the hard part, figuring that out. This view is specifically done for showing dislocation of the humeral head, for shoulder dislocations. So if somebody has an arm hanging down and you just can tell by looking at them that they have a dislocated shoulder, you're automatically going to want to do this view so the doctor can see if it's anterior or posterior dislocated. And then you're going to just do an AP as is, neutral. We're not going to do internal, external because we can't move their arm. So these would be the two views we would do. So that's why this is considered a trauma view.
So you said there's going to be two views, the gray sheet and the Y, correct?
Those,
For a
yes.
dislocation.
No, what's the gray sheet for? We oblique them to see the what?
Oh crap! It's the. I just lost it.
Yeah, the joint.
The joint.
joint. So the Y views for dislocation, and if we can't move their arm and do internal, external, if they're dislocated, the only other view we can do is just an AP as is, a neutral.
Just neutral. Okay.
Yeah. So we would just do those two in a trauma situation. So that's why this view is one we're going to test you on, because you're going to probably end up doing a Y view at some point, especially if you're in an ER or trauma. And there are some orthopedics that they do this as one of their routine views too. This is just recapping everything. 2.5 inches below the top of the shoulder for the scapulohumeral joint. That's where we're having the central ray come out. 40 to 60 degree rotation until that scapula is true lateral. The acromioclavicular joint to the border of the scapula you can feel is the line we're trying to do, straight to the IR. So here's one dislocated and one that's not. So you're gonna see that Y shape here, but instead of really seeing the body, we have the humerus in the way. So that's kind of the straight up and down stick. We want the head of the humerus to be centered in the center of that Y because that's where the connection is for that scapulohumeral joint. If they're dislocated, it's gonna either go forward or backward. Here's the coracoid process, that's more anterior, closer to the ribs, so that's an anterior dislocation. Back here's the acromion, it sits more posterior, so if it's floating over here, it's a posterior dislocation. And I have a slide assignment that we're gonna do later on to talk about that more. So the doctor's gonna shove that shoulder back up into its right spot based off of this x-ray.
So the dislocated side, the one on the right, the Y is right, no. That's the body of the clavicle, or excuse me, the coracle. And then the Y is where?
So now we don't have the humerus for our stick, we just have the body of the scapula, this little wiggly bone here.
Yeah.
And then the acromion over here, coracoid over here.
Okay, so there's the Y. That's okay.
Yes, Sandrika, what you got?
So the humerus is what's leaned to the side right there that stuck out like it's broke.
Yep. This is the head
Like
of
all the way down, the little line is all the way down, you see?
yep, all the way down here. And it has the ribs overlapping it here where you might be
Am I
thinking,
saying it- Hello?
yep, go ahead, say it again.
Scapular?
I heard you say scapula. What's your question though?
Is laid like straight, it's still laid straight down, but it's kind of curved now that it's broken. Like all of that is broken.
Yeah, it might be. It could just be that they're like not totally straight. It could be that we're just seeing a little bit more of the body of the scapula here.
Okay.
They might not be right obliquity. Because we're starting to
So
see.
on a regular view where it's not dislocated, it would be lined perpendicular to each other, like basically right on top of each other.
Exactly, like this picture on the left.
Yes. Okay. Thank you.
Yep, you're welcome. All right, so humeral head and the glenoid cavity should be superimposed like this on a good, not dislocated shoulder. There's another view of it with the labels for you. So remember, acromion sits over here, coracoid is towards the ribs, and then our body and our humerus is all overlapped.
Can you go back one?
Uh-huh.
The dislocated. Okay, you said you'd know if it's anterior or posterior by where the corticoid process is.
Mm-hmm.
Well, the corticoid process is in the front. How would you know that the bone is behind it?
So see how we see the shadow of the head of the humerus in underneath the coracoid?
Yeah, I see that.
That means it dislocated anteriorly or to the front of the patient. If it
Okay.
was posterior dislocation, it would float back here behind the acromion.
Oh, the head of the humerus would be back there?
Here, yep.
Oh, they'd be all
So
food.
this would be an exterior on view.
This is a lateral view because the scapula is lateral. But when the doctor looks at it, he's going to know it's an anterior dislocation based off of this, where it sits.
So if
the
it
head
sits under the corticoid process, it's anterior. If that thing's all the way in the very back, you know it's gone backwards, so it's posterior.
Exactly.
Okay.
Okay, I get that.
Yep. Because coracoid sits up here, acromion sits back here. So depending on which way the head of the humerus flips out, it's going to either go forward or backward. So that's why this is an important view for dislocated shoulders. And you can do this laying down, standing up. Most people, if anybody in here has ever had a dislocated shoulder, they don't want to sit down. They just want to stay in one position. Getting up and down and moving is not fun. So they're usually humped over, standing, holding their arm. So we usually do them standing. As soon as they pop that arm back in, like instant relief. And we do more x-rays. So for the shoulder scapular Y view, we want to see the humerus overlap in the body of the scapula.
So
And
then the only time you use the Y view is to really look at a dislocation.
that's the reason for it.
The reason for it.
I've done it as part of our protocol in the ER, even if they didn't have a dislocated shoulder. That was what our radiologist wants to see. He wants the AP, the internal, the external, and a Y view.
Okay.
It just depends on where
But
you're at.
if you suspect it's a dislocation, that's the only view you're going. That's the only position you're going to use, the Y ladder.
And an AP. Just
And
add.
AP.
Mm-hmm.
Okay.
Just those two. That's all. Yep.
I'm just writing this down for my notes. I just want to make sure I totally understand it.
You got it. Now we're going to do a break if you need one. Anybody need like a 5-minute break before we go on to the scapular clavicle? No? Okay. You sure?
Just don't overload us with too much stuff.
We do have these to do in tomorrow's lab. That way we can get practice in all of these for our comp that's coming up in week 3. All right. So hands up, raise hands, no break. Okay. I need to get my drink. I'll be right back. I've been talking a lot. All right. Let's see, scapula and clavicle. This one's really short, so it won't take us too long. Okay, everybody see that one?
Yes, ma'am.
Waiting on my computer to catch up. I really think I got too much stuff saved on it now. So we know the anatomy already. It's the same as the shoulder girdle anatomy we already went over. Body of the clavicle to the acromion and to the sternum so that we can see sternoclavicular joint and acromion clavicular joint on this side. So this is just the bones. We know that the clavicle sits over the lungs and ribs from doing chest radiography. So that's one of our little issues with x-ray in the clavicle is the ribs kind of get in the way. So you can see on this picture, the clavicle slopes down to connect to the sternum and we have ribs and lung tissue overlapping it. So it could be hard to see a break if it's right there overlapping the ribs. Again, we have this end of the clavicle called the acromion clavicular joint and this end sternoclavicular joint, and then body or shaft of the clavicle. Sternal end, acromial end is what B and D are pointing to. It's going to be a crosswise film or landscape. I'm still used to saying crosswise. And then with scapula, we want to see the whole length of the scapula all the way down to this angle. So we're going to put the IRN portrait or lengthwise up and down to match with the scapula. Scapula is
and that position right there, that's a PA.
AP.
So your back is against the IR.
Yeah, back against the IR, AP. Anterior to posterior.
Okay.
So we have 3 borders that we're going to want to pick out. It's kind of hard to see because again, we have ribs and lungs where it's overlapping. This x-ray really is bright. This side, inside, closest to the spine, that is called our vertebral border or medial border. The side closest to our armpit area is axillary or lateral border. And then we have the angle down at the bottom. So most important thing that you can do when you're positioning this is to find that angle, palpate it, and make sure it's in the light at the bottom. You should have a little bit of light above the top, but as long as you're not clipping that, you're gonna be good. So the body parts that we need to know. The acromion in the back, posteriorly, coracoid in the front, that axillary angle, the vertebral angle over here. All of this bony part is the body of the scapula. Inside, this is a curved out area, kind of that where the shoulder blade curves. It's called the anterior or the costal surface. So our ribs are referred to as costal, so if you remember that, touches the ribs. This little piece is what touches our head of our humerus, so the glenoid cavity here, or the fossa. And that's pretty much all of that. Let me see, I think there was something on the back we need to look at. The posterior surface of the scapula has this ridge on it, the crest coming up to the acromion. And then up here, there's a dip, indentation in it, the supraspinatus fossa, supraspinatus fossa. There's a special shoulder view we do to x-ray this area, so that's why that's important, this little dip in the bone. That's that same picture from before where we can find the coracoid. It's right below, you can feel down about an inch or so below our clavicle there and find the coracoid. That's our Y view again, and this is different from the Y that we looked at for shoulder because we do not have the humerus overlapping it. We moved it out of the way. So AP, this is our position that we want to put our patient in. We put the arm out, it says abduct at 90 degrees in the book with their hand on their forehead. That moves the scapula away from the spine so that hopefully we can see it better. And then the lateral view is the same position. We want the spine or the part we can feel on the back of the scapula lined up with the acromion, clavicular joints, the AC joint straight to the IR.
And that position is an LAO, correct?
Yes, good job. LA.
Finally figured it out.
And we know the joints already, scapulohumeral joints, sternoclavicular joint, acromion clavicular joints. Same picture before. Uh-oh, Shannon got kicked out. Movement types again, just refresh on those. Usually this was 2 different days we looked at it. All right. I think my thing quit working. All right. So 2 pictures for clavicle, AP and AP axial. So once you kind of get one set, it's really quick to move into the next one. Central ray perpendicular to mid clavicle on the AP, that gives us a true representation of the shape of the clavicle, because remember, if you angle the tube, you're going to have some distortion. But we need to angle sometimes. The reason we're angling here is so we can throw the clavicle up off the lungs and the ribs. There's a range 15 to 30 degrees. So let me find the pages for the clavicle for us. Lots of special shoulder views we're going to come back to. Page 204. Somebody look on 204 and tell me why there's a range. What's the difference and when do we use what degree of angle?
I'm just going to guess and say the different angles are for the different how tall the person is.
Good guess.
I guessed.
Not that one though.
Okay,
Close.
somebody else guess.
Kind of close. Sandrika.
It's based off the body habitus?
Yes, body habitus. Do you see it in the book?
Oh, well,
No, I guess because I know based on people body habitus, the positioning can change.
Yes. So somebody else, look in the book. Look on page 204. And
It
it
says thin asthenic patients require 20 to 30 degrees CR angle. Patients with thick shoulders and chest, hypersthenic, require 15 to 20 degrees CR angle.
Yes. So a thicker patient, their clavicles are going to sit higher. A thinner patient, they're going to be more slanted down. So hypersthenic is only 15 degrees, where asthenic is going to be closer to 30 degrees to throw it up. So you are going to need to do that on your comp, depending on who your patient is. Have the right amount of angle.
So AP, when you're doing an AP clavicle, it's just straight on. You just want to take the picture of the clavicle. That's it.
Yep.
And when you say, let's say we pick the card AP axial, and somebody's going to have me as their patient,
They
they're
only
going
need,
to go 15 degrees upwards
yeah,
towards my ears. Okay.
15 cephalic. That's it. So you were going to be remarrying, because when you angle, you're changing the height of your beam, recentering and remarrying. So that's one thing you have to do on the clavicle. 2 pictures, AP and AP axial. This is the 2 pictures of what it's going to look like on your radiograph. So we are still going to have some overlap on the rib area, but most of the body hopefully gets thrown up off of the ribs on the axial shot, or more clavicle is seen above the ribs. This is the one we're not comping on, but you want to know the material for test purposes. In case you get a chance to do it at clinic, you can do this one. Super easy. This is acromion clavicular joints. We're going to do 2 pictures, one with weights and one without weights, so we can see the pooling of the joint space opening up. 72-inch SID, and I will tell you, I've only done this one time ever in almost 20 years. But depending on where you work, you may get them more, especially with working around where, well, if football comes back, the Jaguars and things like that at the orthopedic centers, you may get players with injuries and stuff where you're gonna be doing AC joints. 72-inch SID so that we can reduce magnification and be able to fit both joints on the IR. And let's see, one big note, page 205 is where the AC joints are. That we want to have weights, about 8 to 10 pounds of weights. So highlight that to be able to pull the joints down. You want to mark it with, see how there's a second little piece of lead up there above the lady's head or shoulder? That is the shoulder marker that says that it's with weights or weight bearing. There are lead markers that say different things that you can add to your board before you take the x-ray. And yes, it's okay, you can annotate afterwards digitally too. So on the note, it's in bold, it says the weight should be attached to the wrist so that the hands and arms and shoulders are relaxed. So the reason it says that is if we give it to them and they hold it in their hands, they may use their muscle, their arm strength to hold the weights instead of letting it pull down. So we attach them, it's like a Velcro strap kind of that helps to pull the arms down in the clinic setting. Sometimes those are like sandbag weights and they're used for door stops. So just depends on where you're working. They may have them in a shelf area or they may be over holding the door open, being all dusty. But 8 to 10 pound weights if that connected or attached to their wrist. And then 72-inch SID. And then you just collimate to get both joints on the image receptor. If you were to do them laying down, you could do it with a sheet to pull them down, have the sheet down at the bottom. Most of the time, you're just going to do it standing. So one with weights and one without weights. And we need them marked, both of them. All right. This is our last one, and we are putting this in the mix for the comps. So you're going to do scapula, AP, and lateral. So AP view, we want the arm out 90 degrees. Some people put it up on top of the head. That's not a requirement, as long as the humerus is out 90 degrees. All right, Sandrika, what you got?
Didn't we just do this one, but it was a PA?
We did not. I showed you the picture of the lady standing, just the anatomy of it. Right here.
Okay, This one was the one with the disc located when it was turned to the side and it was kind of oblique.
The Y view,
Yes.
that was for the shoulder Y view. Yep. So we're going to look at the Y view again for the scapula in a minute.
Okay.
So yeah, AP scapula, arm out 90 degrees, hand on the forehead. That brings the scapula away from the body. I do remember kind of saying this already, but I think I was just talking about it in positioning there. Center to mid scapula. So this is a hard point to try to find. Try to find scapula in the book for you, page 207. So how you find mid scapula is 2 inches inferior to the coracoid process and 2 inches over from the lateral border of the patient's body. So find coracoid again, go down about 2 inches, and then 2 inches in or over from the body. It should be in line with coracoid pretty much. And like I said, you can double check by feeling the bottom of the scapula, the inferior portion, to make sure you don't have it clipped off in your light field. It's not a very pretty picture. So I have on here, breathing technique is preferred. Should have put the word orthostatic in that. So look at page 207 and highlight this, note this for your notes. For respiration, it's in bold, orthostatic breathing technique. Does anybody remember learning about that? I don't know how much you've learned about that one. I'm trying to think in chest, did you do it for anything?
No, we did inspiration and expiration, but we didn't do orthostatic.
Did you talk about it in physics? What orthostatic breathing means?
No, ma'am.
All right, so I get to tell you about that. So we have different times we can set for our seconds for our masks. And we usually want really quick times so we don't have motion, right? On orthostatic breathing, we want the patient to breathe through the exposure and have a long exposure so we can blur out the ribs. So we want motion, we want blurriness. So orthostatic breathing is a technique that we do. It's the preferred way to do the AP scapula so we can blur out the ribs and the lungs. We use that breathing technique on a couple of other things we're going to talk about in the program, some stuff in the spine, the sternum, and other positions. So it's a long exposure time, usually 2 to 4 seconds, even 5 seconds long. So with that long of an exposure time, we're going to use really low MA, like 50 MA. Most of our other procedures, just for reference, probably haven't talked about much, are using around 250 to 400 MA. So high MA, so we can use a very short time. So this one's opposite, long time, about 2 seconds or 4 seconds with a very low MA. And just note the book says respiration, orthostatic breathing is preferred. So when you hear a breathing technique or orthostatic breathing, that means we're breathing in the picture. Some students always are like, oh, I thought breathing technique meant like suspend respiration. That's a type of respiration instructions, but orthostatic breathing is the like proper term for it, orthostatic, and then they have the word breathing technique in parentheses in the book. If you don't have a patient that you don't think is going to cooperate with that, maybe they're like having difficulty breathing, really short of breath, and a lot of pain and not breathing right, because you don't want to tell the patient, okay, just breathe normally, because what happens when you're counting respirations and you tell somebody, they're going to start holding their breath or breathing weird. So we just don't tell them anything, and we just let them breathe throughout it, and then we take the picture. So you don't want to let them know, but if you notice your patient's like hyperventilating and a lot of pain, moaning, groaning, and not going to be like normal respirations, then you just do the alternative, which is, in this case, suspend respiration when breathing cannot be used. Yes, Sandrika.
So basically, orthostatic breathing is the process of breathing normally without the patient, monitoring the patient normal breathing pattern?
Pretty much, yes. So we let them breathe through the exposure. We do a really long exposure, so when they're breathing, it's blurring out those structures that are moving. The book picture kind of looks a little fuzzy if you see. You got another question? Are you good? Okay. So that blurriness is needed here so that we can make out the outline of the scapula. And that's just for this view, the AP view. The lateral view, we don't need that. And there's that fuzziness that we see kind of blurred behind the scapula. The ribs look a little fuzzy and blurry. We call that penumbra, that little motion blur. But you can make out the border of the scapula. I actually don't know if I've ever had a scapula order. I don't do scapulas very often. Most of the time, if it's an injury to it, they catch it on the shoulder x-ray. The lateral scapula looks familiar, hopefully. It's just like the lateral scapula Y view that we did, except for you're moving the arm. So we're gonna position the patient. I did kind of go over it a minute ago when we were just looking at the pictures and the anatomy. But you position the patient centered to the mid-vertebral border, so that bone that you can feel, you're gonna center it to the center of that, and position them until the scapula forms that straight line through the acromion clavicular joint to the body of the scapula. And there's two different things we could do here. So this gets a little confusing for you guys. The way the girl's holding her arm now, she's putting her arm across her body. And that's moving the humerus forward and out of the way. This is like 90% of the time what's gonna be done. That shows the body of the scapula, this whole long piece of bone here. And it's on page 208 in the book. There's two pictures there. If we're doing the body of the scapula, this is going to be the way you put the arm across the body to show the body. If we need to see up by the acromion and coracoid, the humerus is kind of in the way there, the head of the humerus. So this one's preferred. They put the arm behind the back. I always say like you're under arrest. That shows the acromion and coracoid. So A and A under arrest, put the arm behind the back, across the body to show the body. So two lateral scapulas you could get. It'll either say to show the body of the scapula or to show the acromion and coracoid. So for the upper part, to see that area without the humeral head in the way as much, we do the behind the back. It drops the humerus down. Across the body, that brings the humerus over it somewhat. So lateral scapula, position them, and then move their arm depending on which one we are needing. Any questions? You can do it laying down, oblique the patient if it's a trauma. We'll talk about that more when we do trauma views. So here's one with the arm across the body. Everybody see that? The head of the humerus is up here across the body. You can see all of the scapula pretty good. So if I give you this picture, it's a scapula for the body. If I give you a picture with the humerus straight down, it's the lateral scapular Y view for the shoulder to see dislocation. Hopefully that makes sense. If you have this picture, that looks like a lateral for the shoulder. The humerus is over the scapula. So lateral scapula is the exact same position as the scapular Y view for the shoulder. The names just get people confused. It's the same thing as the Y view, except for they move the body, the arm across the body. AP scapula, lateral scapula. The lateral scapula, you can move the arm two different ways depending on what you're wanting to see. That gets really confusing when you guys are making your note cards and stuff. All right. So hopefully that makes sense. Any questions? It'll make even more sense tomorrow when we're in the lab. That's all for today. There is two things I want to talk to you before we go. Your assignment for today and then the discussion board. Emma, somebody had a question?
So when we're making our matrix, do you want us, or would you suggest we do two separate box areas for a scapular Y and the
Yeah.
lateral.
Yeah. And then on your lateral, you can probably put notes for the body positioning, one for the acromion and one for the body.
So the scapular Y is to view the acromion and the coracoid, and then the scapulolateral is to view the body.
Yeah. Arm across the body for the body, arm behind the back for the acromion.
Right. Okay.
Yep. All right, let me jump over to Blackboard just to double check today's assignment. I can't remember what it was. And then this week, there's a discussion board post. I forgot to tell you about it on Tuesday, but it's not due until tomorrow. Some people have already done it. It's kind of like what you've been doing, what's up since you've been home during quarantine, getting to know you, kind of interesting post, nothing too hard. So under week 1, daily assignments, there's an assignment for Thursday at the bottom. Oh, it's a link. Okay, I forgot about it. It's a web link that I made and it has some questions in there and it is due via the discussion board. So good, you got your intro and that to do as your assignment for today. So you can get those done at the same time. Let me just share my screen real quick so you can see this and know exactly what I'm talking about.
And those discussion boards are due today by what time?
So the shoulder one's due today. Your one that's the intro one's not due till tomorrow. Just by midnight's fine.
Cool beans.
So here's the positions of the shoulder, the jelly, the little acronym, and some pictures you can mag up, zoom in on them, look at some of the stuff we just talked about. And this is a Quizlet I made. Get to the questions. All right, image analysis book. Look at those images and answer these questions in the discussion board post. So number 1, 2, 3, and 4. So these are the questions you're going to submit and I'll grade it from the discussion board. Don't just wait for someone to post it and copy it. It'll help you better if you do it yourself. And that's it for today. Bye, guys. Oh, yeah, I was going to do tutoring. It's Thursday. Does anybody want to do tutoring? Send me your questions by noon so I can work on them and we'll do tutoring at 1 if anybody wants to do it.
Today, tutoring today,
Yes.
back in here.
Yeah, there's a link, though, for you to fill out for the questions and to meet your instructor. So I'll know what we were going to tutor on and talk about. Anything you want to go over.
Okay, and then I have another question. You're gonna post this, right? And so I can rewatch it and take my note.
Yes.
Thank you.
It should be available shortly. You're welcome. All right, Candace, next Thursday.
I'll be here this Thursday though.
All right.
Thank you.
You can take a break from lawn mowing.
Well, then you tell my wife that, and then I'll be good to go.
Oh, okay. You might want to catch it before it rains.
Yeah, that's as soon as